Hello, everyone. Good afternoon. Nice seeing you all again. At least nice to be with you on Zoom. I hope the message has gone to everyone. This is 17 batch, no?
No, it's a 19 batch.
19 batch. Okay. This is your introduction to GIT in GIT module, yeah? Clinical module, clinical component. No?
Yes, sir.
Right. Okay. All right. Professor Ishan Soisai is the chairperson, I guess, yeah? And I don't know who there is no convener, I think. Right, never mind. Sorry, I had to do this online because my health is not very good today. I'm down with flu. So I'll do as much as possible. It's not you can't cover the entire lot in this 1 hour, but I'll try to uh, give an introduction to GIT so that it will be helpful for your clinical activities, right? In clinical day-to-day clinical work. Right. So let's start. Can we record this? Is better, no? Oh, where is the record button? More record on this computer. Okay.
Recording in progress.
Right. Let's look at the abdominal organs. Abdominal organs. Because in gastrointestinal tract, most of the organs are located in the abdomen. Of course, the mouth, pharynx, and esophagus, they are also considered as part of GIT. But the challenge is really within the abdominal organs. So when it comes to abdominal organs, what you need to realize is that some of the abdominal organs are located, under the rib cage. Under the rib cage. So, which means this is special in children sometimes. You can have referred pain from the thoracic organs to the abdomen, even in adults. You see, sometimes acute myocardial infarction can present as epigastric pain, right, or abdominal pain. I have seen patients and I have personally missed certain things, certain diagnosis, right? So that can happen to anyone. And also in children, you've got to be very careful. Right lower lobe pneumonia can present as right iliac fossa pain, right? It's very interesting and amazing. Once I think when I was in functioning as a SR, senior registrar in Peradeniya, we nearly operated on a patient for appendicitis. But before that, something told me to take a chest X-ray because I wasn't that happy with the clinical picture. But that was almost classic appendicitis, like it presented. He came with right iliac fossa pain. And then the chest X-ray showed the right lower lobe pneumonia. So extra abdominal organs, pain from the extra abdominal organs can be referred to the abdomen. So you've got to bear that in mind. Right. Then Okay. So when you take the abdominal organs, one way of dividing the abdomen is into four quadrants. You can say right upper quadrant, left upper quadrant, right lower, and left lower quadrant for description purposes. And you must have a rough idea as to where these organs lie, right? The surface marking of the liver. You have to know where the upper margin is, and where the gallbladder is. You can remember the surface marking of the tip of the gallbladder? Hey, are you sleeping? Gallbladder? Sorry, not tip. Fundus of the gallbladder is
Tip
surface mark at the
of
tip of the
and
they are 9 right costal cartilage. And how do you get that? Generally, roughly in the midline. Oh, there is a step when you feel the costal margin, right costal margin. Roughly, you can say it's mid-clavicular line, or else there is a little step. Can you see that step here? You can feel it when you feel along your right costal margin. You can feel you can feel a step. That's where the gallbladder, the fundus of the gallbladder, right? So even other organs, you must know roughly where the transverse colon is, and you can see the colon is large bowel is in the small bowel is in the midline, roughly center, not in the midline, in the center. You take X-ray. Sometimes you do X-ray for bowel obstruction to see, gas fluid levels or whatever it is, right? Dilated bowels. When there is a dilated bowel fluid, you don't know whether it is small bowel or large bowel. One way of identifying is the large bowel is in the periphery. The central part contains small bowel that is in supine position. So you do supine X-ray abdomen, right, in abdominal pain or distension. And if you want to exclude the perforation, then you do erect chest X-ray, because that you see the diaphragm, because diaphragm goes right here up chest X-ray and spine abdomen. That is, you do those two, right? And you can see the sigmoid colon on this side. Sometimes, depending on the sigmoid colon, the length of the mesocolon has a very, very long sigmoid colon. So that sigmoid colon can come to the scrotum. Even the transverse colon can come to the scrotum. I have seen cases, right? But and the appendix obviously can can herniate sex, right? Uh, Descending and ascending colon, very unlike, because they are plastered onto the posterior abdominal wall. Okay, right. So then, to be familiar with these 9 regions of the uh, abdomen, right? So you have the subcostal margin. And that subcostal margin is which level? 4, 5, no, 5, 4, 3, 2. Is it lower body? Somewhere there? Then you have to be familiar with point of the iliac, but not the 9 regions. You take the intertuberosity plane. This is the anterior superior iliac spine. But when you go a little higher, you see a little tuberosity, little wide, little broadened area. And that's called the tuberosity, iliac tuberosity. So if you're there, that's the intertubercular plane. And then you take your mid-inguinal and mid-clavicular line. So you have your 9, right? This has to come a little to this side. So you have the right hypochondrium, then epigastrium, left hypochondrium, then the umbilical area, and the right lumbar and the left lumbar, and then the right iliac fossa, left iliac fossa, and uh, hypogastrium, or you can call it suprapubic area. Never come to the exam without knowing these 9 segments, because those are important when you are describing a lump or pain or whatever it is. This is the communicating right language with the consultant. So you can easily say the moment you say that the patient with pain in the left hypochondrium, you know it's you know where it is really, and you know the organs there, right? So right. Then very often you deal with the groin area, so you have to be familiar with surface markings. Here what is this? Sorry. You go along the midline like that, and then you hit the symphysis pubis, and then go laterally, right? Now you have to excuse me for a minute, right? I'm going to pause this and then I'll restart this, right?
Recording stopped.
Right. We will
Recording
start
in
again.
progress.
Right. Can you see my no, you can't, no? Your screen sharing paused. Can you see my screen? Hello?
So it's the same thing as before.
You can see my screen, no?
Yes.
Yeah, my drawings, see whether you can see, right? So you go down like that and hit the symphysis pubis, and then go laterally, and you can feel the pubic tubercle. But in obese patients, it's not easy, I understand. So, yeah, but if you know that you give some allowance for soft tissues as well when you do that maneuver. So anyway, this is your pubic tubercle. And here, of course, anterior superior iliac spine is not a challenge. Any fool can identify that. The moment you keep your hand there, you know where the pointing anterior superior iliac spine is, right? So
Sir, we can't see your drawings.
you can't see, no?
No, sir.
Stop share. Right. That's the midpoint of the inguinal ligament. 1.25 centimeters above that. Just above that. You can say you don't have to remember all these centimeters and things, just above that. Huh? What do you get there? Yes, that's the deep ring. So if there is a hernia, you reduce the hernia or ask the patient to reduce the hernia. First, you have to reduce the hernia, otherwise you can't do this maneuver. Then you keep your thumb over this, ask the patient to cough. If it comes, then you know it is coming medial to that. If it doesn't come, then you know it's a indirect inguinal hernia. So direct hernia will occur medial to the deep ring, right? Just medial to the deep ring, what is there? Any vessel, blood vessel? What is the blood vessel going like that up? Inferior epigastric artery. So indirect hernias occur just lateral to the inferior epigastric artery. So here you have another muscle, no, which prevents direct hernia. What is that? Your six-pack muscle. What does that mean? Rectus abdominis. So lateral board of the rectus abdominis, inguinal ligament, and inferior epigastric artery. What is that triangle? Hasselbeck's triangle. So that's where you get your direct hernias. Direct hernia. So, and if you take on the other hand, the mid symphysis pubis and the anterior superior iliac spine, and then draw a line, that is called, and if you take the midpoint, that is the mid-inguinal point. Mid-inguinal point. So somewhere here. And that is where you get your femoral artery. So mid-inguinal point is in the over the femoral artery. Midpoint of the inguinal ligament, just above the midpoint, is the deep ring. So deep ring has to be little lateral to the femoral artery. So remember those things when you do your surgical appointment. Right. And so it's important to feel the pubic tubercle. And if you go 3 centimeters below and lateral to the pubic tubercle, 3 to 4 centimeters below and lateral to the pubic tubercle, what is the point you get there? Saphenous opening. And your femoral hernias come out through the saphenous opening. So neck of a femoral hernia is 3 centimeters below and lateral to the pubic tubercle. And the neck of an inguinal hernia is always above and lateral. Above and medial, because where is this rectus? Sorry. This is the external ring, no? External oblique aponeurosis. So your cord comes like that. It comes above and medial to the pubic tubercle. So basically, inguinal hernias, they occur above the inguinal ligament. Femoral herniae, they occur below the inguinal ligament. So remember those little things, right? So what we discussed, right? This is the midpoint of the inguinal ligament, and that is the mid-inguinal point. Okay, that's pubic tubercle, right? And that space provides transmission of all the vessels and nerves from the abdomen to the lower lip. And this is the symphysis pubis. Right. So those are your 9 regions, right? And the other thing you have to know is a lot of people come with abdominal pain. Abdominal pain. And you see, so you need to find out which abdominal organ gives rise to these abdominal pains. Is there easy way of narrowing down your diagnosis? Can someone tell me? Well, the abdominal pain can arise from solid organ or hollow organs, right? So, what are the solid organs you know in the abdomen? Liver and spleen. Those are the two important solid organs. Of course, don't forget the kidneys, retroperitoneal structures. These are intraperitoneal, and don't forget the retroperitoneal. Now, retroperitoneally also you have certain organs. So, patients coming with abdominal pain, don't forget the retroperitoneal organs like kidney, duodenum, pancreas, right? Those are all retroperitoneal. No? So, solid organs will give rise to continuous pain. Continuous pain. Whereas the hollow organ will give rise to a colicky pain. But for you to have a classic colic, you need to have the correct diameter. If the diameter is too large, you won't get a colic. And also, it has to have strong musculature also. Strong musculature. So that when there is obstruction, calculus or whatever it is, it tries to eliminate, it tries to get rid of the calculus. In doing so, this muscle goes into spasm. So when the muscle goes into spasm, its blood supply goes for 6 because always it's in contraction. So there is ischemia to the muscle, and that ischemic pain is the colic. You can imagine it increases with time, and when the muscle is almost paralyzed, exhausted, then the pain should stop. Right? So pain comes back to 0 and then again starts when the muscle recovers. Yeah? That's how you get a colic, no? So what's the classic example of a colic? Renal colic. In fact, ureteric colic. The correct name is ureteric. No, renal. So, yeah. And then the other colics are small bowel, not the large bowel, right? Small bowel. And gallbladder, of course, it's like a bag. It's not a true hollow viscous. It's not a, it is a hollow viscous, but then it's not like this. No, it doesn't fulfill the criteria for a true colic. So it produces pseudocolic. It's almost continuous pain you get. Then it lasts for a couple of hours or days or whatever, right? So the other thing is, all these structures you can divide into 3, depending on the embryology. There are foregut structures, right? And there are midgut structures, and there are hindgut structures. This is important because foregut is, the pain is carried via sympathetics. Foregut pain is carried via sympathetics to the around C6, C7 segments of the spinal cord. 7, 8, that area. Normally, the somatic supply of the 7, 8, that area is the epigastrium. Epigastrial area. Therefore, the pain coming from the foregut structures refers to the epigastrium. So, if there is a patient complaining of severe pain in the epigastrium, you got to think that it could come from liver, duodenum, the first part, the upper part, the second part, right? Proximal part of the second part. So, what are the other foregut structures with? Liver, gallbladder, biliary system, common bile duct, and pancreas. So those structures can give rise to pain in the epigastrium. I don't know how many of you will grasp these things, but this is the very basis. If you know these facts and if you apply this to your common day-to-day life, you will become a good diagnostic. Your diagnostic skills will go sky high. And midgut structures, similarly, the pain will be referred to the umbilical region. And the hindgut, like diverticulitis and things, right? The pain will be experienced in the hypogastric or suprapubic region. Of course, there are other structures which give rise to hypogastric pain, like bladder, like left hypochondrium, the spleen, like that. Okay, fine. So that's the pain. I told you the subcostal levels and things. I don't think you need to buy hard, but certain things. Highest point of the iliac crest, people might ask, because for lumbar puncture you use that, no? Highest point of the iliac crest. Can you see that? That's L4 level, no? L4 level. What is the other important level of the L4? Can someone tell me? What happens to the aorta? Aorta divides at the lower end of the L4, no? Into common iliac arteries. How can you surface mark in a thin individual the division of the aorta? Yes. No. Ayyo. Umbilicus. So if you get a pulsatile aneurysm, if you get an aneurysm, pulsatile mass above the umbilicus, it is probably abdominal aortic aneurysm. If it is below the umbilicus, unlikely to be an aneurysm from the abdominal aorta. Right. So remember those little lines or little levels, right? Right. Other things are of anatomical importance, but clinically, well, sometimes it is important because when you count ribs, this is important when you put the intercostal tube, but that's for surgery, not for GIT so much, right? To count the ribs. If you insert your hand into the axilla and feel the highest ribs you feel, that's the second rib, no, not the first rib. That's one way of counting. Inferior angle of the scapula is at the level of T7. L4 is the highest point of the iliac crest, and the S2, I must have told you. So this sacral dimples, dimple of Venus, that's the S2 level, no? That's where the dura mater ends. That's where you get to middle of the sacroiliac joints also, right? That's not a good. Right. So apart from that, in GIT, a lot of other things I don't want to sort of waste your time. I can go to town and discuss stomach, intestines, duodenum, colon. There is no end, right? But I gave you some basic facts. The others you can go and refer, right? Doesn't matter. But remember these foregut, midgut, and hindgut pains and these levels, these these 9 regions of this, and those salient points I highlighted, mid-inguinal and midpoint of the inguinal. Those are very frequently asked questions at exams. Right? And these will be very much useful in your day-to-day life. And don't forget about the retroperitoneal organs as well. Someone asked where the kidney is, right? at least you must know which level. Now, most of the kidney is here. Now, it is posteriorly related to the 11th and 12th ribs. So, if you feel your 11th and 12th ribs posterior, you know how high the kidney is, no? And what is the length of the kidney normally? It's about 2.5 to 3 vertebrae in X-ray, right? 2.5 to 3 vertebrae. So, the lower part of the kidney is really at probably L3 level, no? So it extends from T12 to L3, like 1, 2, 3. Yeah, this lower board of T12 to L3 level, like no. So rough idea you have to have, and the position of the kidneys either side of the vertebral column. So either side of the vertebral column means it's not directly anterior posterior axis. It's slightly, posteriorly it's fading away like laterally. You can understand. I mean, that has to accommodate to the shape of the paravertebral gutter, Hmm? And remember the relations. That is also important. And in fact, whose bed is this? What is the abdominal organ in front of this? Yeah. Yeah, there's the stomach bed. No, I have yeah. Right. Sorry. Stomach bed. Stomach bed. The lesser sac is between the posterior wall of the stomach and the pancreas and things, right? So that's the stomach bed, no? So remember those little relations, right? Okay. So I don't intend delivering a lengthy lecture because we won't remember much. So any questions you want to ask? So, right. If I don't retire, no, I won't. No, during your professorial time, we can take few surgical anatomy classes. Then I will revise these facts again to you, right? So yeah, that's it. I think. So we will stop there. Easiest thing is when you get a case, always go and refer anatomy pertaining to that very briefly, not much surgical anatomy, right? Not from anatomy books, surgery books, right, or any articles, because that is the basis, no, right? Don't buy hard things. Remember the principles I mentioned. Okay, shall we stop then? Yeah, you can ask any question if you want. Okay, I'll end the meeting here, right? Thank you.
Recording